Thank you very much, Dr. Chauhan and Team Physicians Forum of India for inviting me to be the moderator out here. This evening we would obviously be discussing ARNI, as has already been reiterated time and again by Dr. Chauhan. Its place in heart failure along with the other important molecules which form the cornerstone of therapy in heart failure. And we have Dr. Viveka Kumar, who actually needs no introduction to this August forum out here. He is the director, PanMax director, cardiac cath lab, and is a very senior and very brilliant cardiologist, as we all know. And after that, it will be followed by a panel discussion. My job is to be just on the sidelines. We have three very senior, very great physicians out here. Dr. Chauhan, the great man himself, Dr. JPS Tulsi, and Dr. Anil Gupta, all very respected in their in the field of medicine, and they will be carrying the discussion forward. So my job would be to be the innocent bystander, said, as it would be there, and just hand over the panel discussion to them. So over to Dr. Viveka for his talk. Thank you.
Well, so good evening to Physician Forum of India, and special thanks to Viveka and Anand, who has been chasing me everywhere from Delhi to Lucknow to everywhere. So I think yes, and Ujjwal and the team, everybody is here. So if you look at the heart failure, this is something which is absolutely it's like a pandemic proportion, and one molecule which has really changed the landscape of heart failure is ARNI, as Dr. Chauhan has said. There are, of course, multiple pillars of heart failure treatment, as we say that the four pillars and fifth and sixth upcoming, but definitely nothing is as revolutionary as the ARNI would be. And it all started with a trial, we call it Paradigm HF trial, which really showed that how the repeated hospitalization decreases, how, and that too was not compared with placebo. That was best in the class at that point in time was enalapril, that is ACE inhibitor. So definitely this is something which is absolutely revolutionary. So if you look at the patients who have ARNI, so in heart failure, if you look at the place of the ARNI, that is pivotal. It is something which is which cannot be replaced by any other molecule. So as all of us know that it has two components. One is the valsartan and the other is sacubitril. Sacubitril-valsartan combination acts on both the pathways. So ARNI would not only do the inhibition of angiotensin receptors, but also the patients initially, intuitively, people felt that probably in heart failure reduced the ejection fraction is going to work, and then we had understanding about heart failure with reserved ejection fraction and mid-range ejection fraction. And mid-range ejection fraction, you would know that it did not exist before the ARNI came. So once the ARNI came, people started feeling, and we got an idea. There are a lot of patients who would improve with ARNI, and we looked at the mid-range ejection fraction patients, which is ejection fraction 40 to 50%, so or 35 to 45%. So these will be different definitions. So in all the heart failure patients, ARNI did work, and we also had the other pillars like beta blockers, MRA. So if you look at the role of MRA and beta blockers, and then later on we had an access to what we call SGLT2 inhibitor, and that also showed quite promising results. But it did not get glorified, the results of MRAs and beta blocker, till the ARNI came. So they were basically an unsung hero in management of heart failure, and the importance of these two molecules was really not brought to the fore. But when we saw and started investigating and looking at the effects of ARNI, we saw that probably the MRA and beta blockers are no less contributor to improvement in outcomes. And then we said that, okay, let's clarify that there are four pillars of heart failure, in reduced ejection fraction, which is beta blocker, MRA, mineralocorticoid receptor antagonist, then the ARNI, or those who do not tolerate ARNI for some reason, ACE or ARB. So this is something which is all in one cluster, and then you have the SGLT2 inhibitors. These were the cornerstone of heart failure treatment. And then in mid-range ejection fraction also, as I said, they behave exactly as the heart failure with reduced ejection fraction. And then there is an entity called heart failure with preserved ejection fraction, where also RP showed promising outcomes, though it was not statistically very significant, but nonetheless it can be used and should be used in this heart failure with preserved ejection fraction group also. So if you look at the latest guidelines, whether it is American Heart Association, ACES, or American College of Cardiology guidelines, or ESC guideline, we see that the heart failure with preserved ejection fraction, obviously the SGLT2 inhibitors and MRA are the two things which have really shown to improve the outcome. Loop diuretics is something which is for symptomatic benefit but has not really translated into the improved survival and all. So we can say that the two pillars are MRA and the ARNI, which can be used in this situation, and then the SGLT2 inhibitor. So SGLT2 inhibitor has got a very good, or I would say that the most important role in heart failure with preserved ejection fraction. If you look at the management of comorbid association with HFpEF, there is patients who have got atrial fibrillation, hypertension, coronary artery disease, diabetes, and chronic kidney disease. So if you look at these chronic kidney disease, diabetes, and coronary artery disease, and hypertension, in all these situations, the ARNI is again something which is going to help our patients. So now we have got many societies where ARNI has been approved in patients with resistant hypertension as well. So patients who have got uncontrolled hypertension or plain simple hypertension, to prevent them from slipping into HFpEF, we can use this. And especially in patients who are obese with heart failure, even with obesity with preserved ejection fraction, now we have got a lot of data slipping in with what we call semaglutide or GLP-1 receptor analog and tirzepatide, which is going to be launched in India very soon. So I think we need to be mindful of the fact that there are new players coming in this field. So patients who are obese have got heart failure with preserved ejection fraction, we need to use this molecule as well in this setting. If you look at the starting and target dose of guideline directed medical therapy for HFpEF, that is heart failure with preserved ejection fraction, there is a very compelling data from empagliflozin and dapagliflozin in this situation. And then we, as I said, MRA, we have got fine arts study from in non-steroidal MRAs, which is Femrenon, which has shown to have decreased the hospitalization and even the mortality. So I think this spironolactone will go into oblivion, those patients who get side effects of this, and ARNI and ARB. So these are the things which are going to be utilized in future in patients with heart failure with preserved ejection fraction. So what all we need to give to the patients where so remember that there are a lot of patients with heart failure with preserved ejection fraction. They are being treated as COPD and lung disorders, which they do not have in reality. They are suffering with HFpEF. So in these situations, we can give them SGLT2 inhibitor, we can give them MRA, and we can give them ARNI, and those who do not tolerate ARNI or cannot afford it, then we can give them ARBs. But very soon we are going to get in the guidelines that we can give them the non-steroidal MRAs, which is Femrenon, and then there is a very strong role in especially the obese patients after the fine arts study of the GLP-1 receptor analog. So that is going to be something which is again very revolutionary, because this is something which will not only decrease the weight of the patient but also heart failure hospitalization and other endpoints. So if you look at the RAS inhibition with ACE inhibitor or ARB or ARNI, all these things you can see it has become a class 1 indication for patients who have got heart failure. So I think the ARNI is something which is very has established this place, as Dr. Chauhan said, that it started in 2016 after the Paradigm HF trial, and we had many meetings. But now we are trying to place and say that in true perspective, where does ARNI stand? It stands very prominent pillar, one of the most prominent pillar in the management of heart failure, be it heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and heart failure with preserved ejection fraction also. So if you see the treatment of HFrEF, obviously we need to start early. So a lot of people would feel that unless the patient needs hospitalization and is in really very dyspneic, you should start this treatment. That's not true. We should start it early in class 1 or 2, and that is why the guidelines of German Society of Cardiology and other societies has come that we should use it as an antihypertensive agent also, and in resistant hypertension, so that you do not bring your patient, let your patient to slip into the heart failure with preserved ejection fraction. So HFrEF should not be there. And again, we have got a lot of data which suggests that if the patients do not really tolerate or afford the ARNI, then we can go to the ACE inhibitors or ARB. But again, if you look at the ARNI, should not be administered concomitantly with ACE inhibitors. So we still do not see, have not sensitized a lot of physician community that you should not immediately switch patients who are on ACE inhibitor and give them concomitantly ARNI, because quite a few of them, they might go into anaphylactic shock. So we should give at least to the patient who are on ACE inhibitor. In fact, I've seen 3 prescriptions today in my clinic that the patients have been given not only ARNI but also ACE inhibitor. So though they tolerated well, but there are quite a few of them, almost 5 to 10% of them can slip into serious allergic reaction, what we call angioedema. So there you need resuscitation and all those kind of things. So you should not give them together. And the window period for washout time of ACE inhibitor before you start ARNI should be 36 hours. So what are the evidences, as I said to begin with, is that Paradigm HF was something which was really revolutionary. But then we did have the data from Paraglide HF and Paragon HF trials, where we were looking at the ARNI in mildly reduced and preserved ejection fraction, a pre-specified participant level pooled analysis. And that what it showed? It showed the pre-specified participants level pooled analysis and Paraglide HF live or Paragon HF secondary pooled analysis. Nearly more than 5,000 patients were there, and you can see that definitely, and that is why I said that we can use this molecule in preserved ejection fraction also. So you can see that clearly there was cumulative events were significantly lesser when you compared with the best-in-class case in ARB, that is valsartan. There was 7.5% reduction in event rates, and also the mean cumulative event rates were significantly lesser in ARNI group, that is total worsening of heart failure events and cardiovascular death. And this was 2 years follow-up, and you can see the graph kept on separating. It means that the benefit was not only for short term but also continued to over a longer period of time. Cardiovascular benefit most apparent in patients with those who had ejection fraction slightly below par, that was less than normal values, and you can see that the risk-benefit ratio, that is odds ratio, was heavily in favor of patients who have had a low ejection fraction. You can see with the valsartan sacubitril combinations, you can clearly see that the patient who had slightly lesser than normal ejection fraction, or those who had a heart failure with reduced ejection fraction, the outcomes were much more impressive compared to patients who have got preserved ejection fraction. So the pooled analysis of Paraglide HF and Paragon HF did show that the ARNI reduced the cardiovascular and renal events. So a lot of patients would say that my creatinine is high, so should we use ARNI? So the answer is yes. As far as the eGFR is more than 30, we should be using, because the patient will accrue not only the benefit of heart failure, but also the benefit in terms of, as far as the valsartan is the renal outcomes are concerned. and the benefit appears to accrue rapidly and strategies to be significant reduction in cardiovascular event, and that happens very early. Even first 1 to 2 weeks would be there. Cardiovascular benefits are more apparent in patients who have got lower ejection fraction, and ARNI increase the risk of, that is Secumada, increase the risk of symptomatic hypotension, but reduce risk of worsening renal failure when compared to valsartan. It means that, when you compare with the Western class valsartan, we had data with valsartan in JAM trial, which showed that the ejection fraction, the heart failure hospitalization is lesser with valsartan in JAM trial, but it was much more effective when you give them ARNI. And real world comparative analysis also did show that including a population of patients with heart failure with reduced ejection fraction, so mid-range or the HFrEF, the ARNI did show that there was a significant improvement in relative risk reduction of all-cause mortality. So definitely when you are giving ACE inhibitor ARB in HFrEF or mid-range ejection fraction, then you should always ask the question yourself, that is it, there has to be a compelling reason for not giving ARNI in those group of patients. So ARNI protects against heart failure by preventing the degradation of cardiac nitripeptides, that is ANP, BNP and CNP, vital for systemic homeostasis. So ARNI is something which is not only improves the diastolic and left ventricular function, reduce the risk of ventricular arrhythmia. So that is why when you look at the paradigm HF trial, there was significantly reduced sudden cardiac death and the improved quality of life. So there are few patients where the ejection fraction has not improved, but the patient's quality of life has improved. So will ARNI be protective and therapeutic in HFpEF patients with comorbidities? So patients who have got, protection in patients HFpEF means the patient's ejection fraction is well maintained or even supernormal, but the patient's diastolic relaxation properties are not normal. So we say that more than grade 2 diastolic dysfunction, as some of you might have seen the echocardiography report, and there it shows that the reduced diastolic dysfunction. So diastolic dysfunction is also addressed by ARNI, and this is something, there are not many molecules. So all the molecules which are effective in heart failure with reduced ejection fraction do not translate benefit into the HFpEF, that is preserved ejection fraction. Definitely beta blocker is something which is not helpful in that situation. So if you look at the HFpEF evidence with ARNI, there is a beneficial effect, significantly decreases the NT-proBNP. There is notable reduction in cardiovascular mortality and rehospitalization. And the trial which really brought this data was the Paragon HF, that showed that the overall improvement in the women was more pronounced than compared to the men. And when we combine the men data with and the women data, then the statistical significance was not reached. So if your patient is women, then definitely they are going to benefit much more. There are better preservation of renal function, especially in elderly. So older patients should need this thing. And combined analysis of Paradigm HF and Paragon HF indicated a potential benefit in individuals with heart failure with reduced ejection fraction. So those patients who have got even a marginal decrease in the ejection fraction, they would definitely benefit. And we know that a lot of them would slip into slightly reduced ejection fraction as well. The HFpEF management guidelines also says, and if you look at the Heart Failure Association of India meeting, which they have, the meeting is going on right now in city of Cochin. There also this management reiterated that especially if the patient happens to be a female, has got preserved ejection fraction, and even if they have got slightly lower ejection fraction than 57%, they will be benefiting. So ARNI is something where the left ventricular remodeling is there, and left ventricular we call it positive remodeling and negative remodeling. So positive remodeling is the good remodeling. So wall thinning and chamber dilatation, something which is decreased by ARNI, and it also promotes both contractile dysfunction and rhythm disturbances is countered by the ARNI in these patients. So therapeutic intervention in pathological ventricular remodeling is something where the RAS system has got a very strong role to play, and also for the energy conservation we say that the SGLT2 inhibition is something which is of very importance. So role of ARNI to reduce the early remodeling, we know that the group HF and evaluate HF data, which was done with the sectoral and certain combination, has shown that the remodeling is positively affected. So in this situation, the result of this trial was that the SGLT2 therapy, when added to standard treatment with HFrEF and mid-range injection fraction, is associated with an improved biventricular function. So this is something which is very important, because we see most of the time it is only the left ventricular function which improves, but with this there is a right ventricular function also improvement. And also if you look at the effects of ARNI versus valsartan, definitely paraglide HF data also shows that it has got far more superior effect compared to the valsartan alone compared to the ARNI, which is valsartan second combination. So the win ratio was normally in favor of ARNI in both the de novo and chronic heart failure, and patients who have got heart failure with obviously the chronic heart failure, it's not so. This was something which is beyond chance trial, that this molecule is superior to the valsartan alone. Then Dr. Murray data, which was published in JAC 24, that also showed that change in NT-proBNP from baseline was, you can clearly see, was significantly reduced, which is again a marker of the response to the treatment was significantly better in patient group which were on the ARNI. Treatment with medical therapy for heart failure with mildly reduced and preserved ejection fraction, because they behave similarly. So if somebody has got ejection fraction of 45, 50% or 55%, in those group of patients, the combination of MRA, SGLT2 inhibitor and ARNI is something which is going to be revolutionary. In patients with mid-range ejection fraction, that is ejection fraction something 50% or less, and more than 40%, so that is where it behaves exactly the same way as the heart failure with reducing ejection fraction. And in these situations, if you look at the HACA multi-center retrospective trial, that also show that the heart failure with mid-range ejection fraction, they respond very well, and especially in patients who have got even the chronic kidney disease, there also the ARNI behaves better and the outcomes are better. Not only the heart failure outcomes, but also the chronic kidney disease outcomes are much better. So the combination of beta blocker, ACE inhibitor, SGLT2 inhibitor and MRA antagonist is something which is called pillars of heart failure treatment. But what about the heart failure triple treatment? Triple treatment is where you're not giving the patients the MRAs, and there also the outcomes with this is much better. So this is a meta-analysis where nearly 30,000 patients were included and triple therapy was given, and look what has happened, that the benefit was more pronounced in patients who have got heart failure with mid-range ejection fraction. So when we say that in echocardiogram and the NT-proBNP is high, echocardiogram shows that the ejection fraction is more than 40%, but it's not totally normal, then it is better to treat them as HFrEF patients, because I've seen and the data also suggests that the combination therapy would improve the outcome in these group of patients. Not only the statistical significance, but clinically also they do much better. So if you look at the SGLT2 inhibitor, that is dapagliflozin, has shown that in these group of patients, the DELIVER trial also showed that in HFrEF and HFMRF, that is mid-range ejection fraction, nearly 6,000 patients were included, and there also the combination of ARNI, MRA and SGLT2 inhibitor did wonderfully well. So in mid-range ejection fraction, we should try to use all the pillars of heart failure. So if you see in advanced heart failure, we see that if the patient has missed the bus and has gone to stage 4 heart failure, then don't expect the similar outcome. So there, the benefit would not be as much as in patients who have got class 2 or class 3 symptoms. There, the outcomes will be much more pronounced. But if the patient goes to stage 4, then definitely we have missed the bus. So if you look at the real world experience with ARNI and HFpEF, definitely the real world data is also again promising, and we have seen that the usage has gone up, and in our practice also it has really gone up in patients. So in HFrEF, we use all the 4 pillars of heart failure medication, and heart failure with preserved ejection fraction, we use the SGLT2 inhibitor, the MRA, and the ARNI, so what we call triple therapy, and which has really shown to improve the outcome. So that is what the treatment algorithm for heart failure also says, that we should classify our patients of heart failure with reduced ejection fraction, mid-range ejection fraction, and preserved ejection fraction. So in HFrEF, we need to use all the 4 pillars of heart failure, that is MRA, SGLT2 inhibitors, and the ARNI, and patients who have got preserved ejection fraction, definitely the SGLT2 inhibitor and the MRA plus the ARNI would be things to go for. But in patients who have got worsening heart failure, there the new molecule variciguat would be something to come up, and that is going to be probably the 5th pillar of heart failure management. So thank you very much for your kind attention.
So please come here. I would give it to Dr. Sen Gupta to start the proceedings and to have his perspective on the wonderful deliberations that we just had.
So, thank you, Dr. Viveka, for a very wonderfully eloquent lecture on heart failure, and dwelling on the insights and the newer insights also with respect to kidney function, dysfunction, etc., and how to place it in the management of heart failure patients in terms of therapeutic strategy. So, before I put it open for discussion, I'd just like to ask the House, how do you think the sacubitril was combined with valsartan and no other ARBs in terms of the initial trials that were taken up? Any inputs, anybody? No.
Why sacubitril combined with valsartan?
With valsartan and not the others.
Why not other ARBs?
ये तो मैं पूछने वाला था.
So,
Could you answer?
yeah. So, my insight is that contrary to the, what we use out here in our country, telmisartan or olmesartan primarily, valsartan happens to be the most widely used ARB the world over. So that is why when it was combined, the molecule which has the maximum evidence was taken into consideration and combined. And it is available worldwide by the name of Diovan, which in India is available only for the CGHS patients because that commands a premium price. The Indian brands Starval and the other ones which are there are much lesser, but for reasons which is very specific to the Indian prescribing scenario, we use telmisartan and olmesartan much. Olmesartan is hardly used in the Western world. So apart from that, Dr. Viveka has beautifully, dwelled on the treatment strategies, and the thing is what we often overlook is that in such patients who are going down, and heart failure is something which is often not picked up. It's a huge epidemic which is there, and we have to see that the patients do not get repeated infections. That compromises the heart failure function even more. And then such patients, once you have diagnosed and are there, should be part of a heart failure program with experts like Dr. Viveka, so that one knows when the mechanistic devices etc. can be offered to the patient. So one should not try and just for the sake of pulling on the patient do that. To give optimum quality of life, they have to be as and when the things may need to be, LVAC, different pacemakers or whatever, that's a separate discussion altogether. But for a heart failure expert like Dr. Viveka, he has to be in the loop. Lastly, we need to know that, in all our management strategies, we need to regularly check our patients and give the best possible advice in terms of whatever is there in terms of strategy for management of heart failure. Unfortunately, that often doesn't transgress into the adoption of the same by the patient, but nevertheless we must do our best. So before and I'm very happy today that Dr. Tulsi is out here, so he has promised me to be extremely humanitarian in his approach today. So before I open it up to the rest of the panel, the August gathering, Dr. Koda sir. Mike sir. Dr. Koda sir. I am just the innocent bystander still. These are the erudite panelists of, please, out here.
So, Dr. Viveka, you asked that if you are using ARNI, you should stop at least 36 hours before starting this combination. Is it true with ARB also?
No, so I think if you see with the ARB, you don't really need to stop it. So that is the advantage that the patient, because valsartan is something which is an ARB, so you can straight away go ahead with the ARB. In fact, there are many situations where the patient's blood pressure is not controlled. You can even give concomitant ARB also. It is only the ACE inhibitor which you have to give a holiday.
So that angioedema is only with ACE inhibitor, not with ARB. So my next question, last question. If you are using SGLT2 inhibitor, ARNI, this combination and other beta blocker like antihypertensive, which works as a antihypertensive also for heart failure. If patient gets hypotension, then which drug you will stop first?
I think the drugs which do not give you mortality benefit like nitroglycerin, diuretics, then so the ARNI should be the last drug to be stopped.
ARNI and SGLT2 should not be stopped first. Yeah, thank you.
So, any more questions before I leave it open to the elite, Dr. Mamish?
I didn't listen to your lecture fully. I came late, but I have heard previous also. My bystander observation, like sir is a bystander, I am also a bystander in cardiology. Moment you start ARNI or Weimara, whatever you call it, invariably systolic blood pressure.
Sacrament. They're feeding you this. Don't you dare say Weimara.
So invariably the systolic blood pressure never goes above 100. And I take it as a standard कि भाई हाँ ये होने ही वाला है सेक्यूमाडा के ऊपर. Is my understanding correct, or I'm just asking from the oncology perspective?
No, so the blood pressure has to be, we should not level it. So there is a clear-cut difference now in defining what is hypotension. So unless the patient has symptomatic hypotension, which he feels giddiness and all those things, till that time it is not hypotension in our book. So we should say that if the patient is having normal urine output, does not have a low cardiac output syndrome, does not have, the orthostatic hypotension, does not feel very weak and drowsy and sleepy all the time, then even the 85 systolic is good enough for that, because that data has shown that over a period of time the systolic would improve, the LV modeling will improve. And coming to full circle for your specialty, a lot of patients who have got chemotherapy and all, there we see that, so I would have many hundreds of patients who have had a chemo or radiation induced drop in ejection fraction, and they feel that probably it is end of the world, because the double whammy of cancer plus heart failure would take their life away. But believe you me that when we start ARNI, they improve and they do really well. So I've got many patients in my follow-up where Dr. Vora has started chemo and they felt doomed because the ejection fraction dropped, and then we have revived them back and given it to them that now you can restart the next cycle. So I think that's really wonderful. So I would say that there is no role of preventive starting of unless we have what. And so one marker where you should do apart from echocardiogram is NT-proBNP, and if it is more than age corrected, more than 200 units more than that, we should start ARNI in this situation. And in fact, the other natural corollary of that is that
We have seen that in patients who have got dilated cardiomyopathy with reduced ejection fraction, and then there is an entity which is called improved ejection fraction. And there, if you stop ARNI, then they go back to reduced ejection fraction. But the chemotherapy-induced reduced ejection fraction is one entity where once they have achieved normal ejection fraction, we have seen that stopping the ARNI, and if they do not need any further chemo, they do well without ARNI also.
So,
The asymptomatic hypotension
Should not be treated at all. No.
so Dr. Vora, if you are using cardiotoxic drugs like adriamycin, etc., how often do you do an anti-pro-BNP in terms of a regular follow-up?
After coming here immediately, I have started doing it repeatedly.
Okay, thank you. Dr.
Sir,
Kumar.
how to titrate the dose of the ARNI, 50, 100 and 200 milligram? How we will prescribe it? What are the criteria?
Usually we say that you should start with 50 milligram and then wait for a week and then go for 100 milligram twice a day and then 200 milligram after a week. But it all depends on the blood pressure response to the patient and symptoms of the patient. So if you look at the paradigm HF data, that was on maximum tolerated dose of 200 milligram twice a day. Beyond that dose, it did not do any good to the patient, so that should be the target. And so it should be the blood pressure level and the other parameters, like you need to look at the renal function and all other things. So every 1 week or 2 weeks you should increase the dose, and unless you give 200 milligram twice a day, you will not have the maximum benefit in the group of patients.
Any questions from the August gathering out here before I leave it open to the panel and I sit down in peace?
Why ARNI is better in the female patient?
Better.
Yeah,
It works better in the heart failure in the female.
No, so I think it's just a chance factor. So basically, the anti-pro-BNP level, so the secretion of anti-pro-BNP and the biomarkers were much more higher. So the response to the heart failure was much more aggressive in female patients, and then probably they were not having other comorbidities. So the pure heart failure enzymes were higher. But if you look at the exact cause of why was it better in females, we don't.
Ladies have a stronger heart. Ladies always have a stronger heart. That's one of the backups as well.
Post-menopausal age group, so we don't really know.
Life expectancy ज़्यादा है ना?
If valsartan would have been replaced by telmisartan, would the effect be same?
No, so there is a data which has shown that valsartan is the premium, ARB for heart failure. So the other molecules did accrue some benefit, but the same benefit was not there with olmesartan or telmisartan.
The Valhep trial was very, very significant in which
The Valhep and the CHARM trial did show that.
Now over to the elite panel, Dr. Chauhan, Dr. Anil Gupta and Dr.
Sir, wonderful deliberation as always. I wanted to ask you, sir, what is this pathway, the naphthalene inhibitor pathway, which is so separate from the other pathways in the kidneys? Because end of the day, this naphthalene pathway, how does it benefit the heart failure issue? I wanted to know for benefit of everyone.
Yes, I think it's a dual pathway, inhibition. So basically, if you look at the heart failure, this dual pathway, one is the ARB and the other is the naphthalene. So both pathway causes, the pathophysiological problem in heart failure patients. So it is more of a natural protective thing, but it protects you in acute stage, but in long term it is harmful. So when you give ARNI, it is sacubitril valsartan plus then that pathway is inhibited and overall outcomes becomes much better. So I think this is something which is quite intuitive. Initially it was tried to combine the sacubitril with ACE inhibitor and the other ARDs that did not succeed. It took almost 15 years to come with the, valsartan and sacubitril, and that really became a winner.
Sir, Dr. H.L. Gampru asked that question, and I wanted to ask you, from your own perspective, in your clinical practice, how quickly do you go and upgrade from 50 to 100 to 200?
Every week.
Every week?
Yeah.
And sir, what are the parameters? The pulse, the blood pressure, asymptomatic hypotension, the chest raise? How do you upgrade?
Just the patient tolerability. So if the patient tolerates and has no low, what we call hypophysin syndrome, then we are happy with that.
Sir, I wanted to ask you a very important question. It is never a heart failure alone. It is usually a cardio-renal syndrome. We are also dealing in patients of heart failure with patients of low EGFR. When we introduce an ACE and ARB, it is usually said that a rise in about 30% from the baseline of the creatinine is accepted. Sir, what about ARNI? Is the same thing holds true for ARNI when you start ARNI and you up titrate ARNI? How do you keep a watch on ARNI? Number one. Number two, how frequently do you monitor serum potassium?
Yeah, so I think if you look at the ARNI, we give some more leverage to that because we are treating for both heart failure and the kidney, these things, the cardio-renal syndrome, which is, there is another term, this new syndrome has got, we call it cardio-metabolic renal syndrome. So there again, you need to be much more persistent and perseverance in this situation. So unless the patient has got the renal symptoms, so unless the EGFR goes significantly, jumps more than 50%, so rather than 30%, in this situation we go up to 50% and then see how it is. And if it stabilizes, then we don't really, so unless the urine output starts dropping or the patient gets urinic symptoms, we try and continue and persist with that. And we don't really stop. So I would say that in my experience, not more than 1 to 2% of the patient have the problem.
Sir, my last question. If a patient of heart failure goes into end-stage renal disease and requires dialysis, what do you do to the ARNI cells?
Yes, right now we have got in our unit, we have got trial which has just finished and we have started giving them ARNI in that situation also. The patient who are on maintenance hemodialysis, we give them benefit of ARNI, and the patient who are making any amount of urine, we give them SGLT2 inhibitor and they do better than the patient who are not on them.
Wonderful, sir, for your insight. I would now give it to Dr. S Sen Gupta, sir, our silent assassin.
Dr. Viveka Kumar has given enough insight. I cannot add some. So we should not be afraid to use ARNI even when the blood pressure is on the converting on lower side. We should persist with it and stop or downgrade the diuretics, stop other anti-hypertensive drugs, and start with a very small dose, even half tablet of 50 mg twice a day, and monitor the potassium and the creatinine by every day. Thank you.
Dr. Tulsi, sir, with your elaborate perspective, context, your views, and let's finish it in 5 minutes with you.
So 5 minutes, give me 10 minutes. Sir.
Okay, sir.
Oh.
I give you 10 minutes.
So, friends, again a wonderful masterly talk by our friend, the best friend of our group, the friends, the Physicians Forum of India, Dr. Viveka. So he deliberated on ARNIs in heart failure. I'd like to ask Dr. S Sen Gupta and Dr. Amish talked about why combine valsartan with sacubitril. I am asking you, why combine sacubitril with any other ARB? What are the benefits of combining sacubitril with ARBs? Tell us, sir.
So if you look at the dual pathway inhibition, so that is something which is going to be beneficial in this group of patients. And now we have data that clearly shows that whatever benefit you get in re-hospitalization, the mortality benefit, all of them are above best in class when you compare with enalapril. So when you look at the enalapril and ACE inhibitor, the benefit with ACE inhibitor and best in the class at that point in time was enalapril. When you compare with that, there was 21% reduction in heart failure hospitalization, the mortality rate came down. So definitely this molecule combination with sequential valsartan with ARNI, where with the valsartan really showed that there is a decreased event rates, and that is why this is something which is of paramount importance.
So the benefit of all of us, why do you need to combine sacubitril with an R? Because sacubitril increases the endogenous nitrotic peptide. See, which cause vascular inhibitions, and also it's a vasodilator. RAS inhibitors, Dr. Sen Gupta, are you with us? Yeah. He is there. So RAS inhibitors, of course, will take care about the kind of protection of the RAS inhibition as well. So sacubitril here is causing what? It increases the endogenous nitrotic peptide here. So increasing the endogenous nitrotic peptide is most important here. Very good. So this is the reason why you need to combine sacubitril with an R. Okay, so let me proceed further, sir. What about ARNIs in acute or decompensated heart failure?
Yeah, so if you look at what we call ADHF, and there are a lot of data which has shown that the ARNI is safe and effective in ADHF as well. But we should not, so if you induce significant hypotension, the benefit will get robbed away. So we should maintain and titrate the dose. So that is why in some of the patients we try and go half the dose, though it is not recommended. We say that it's off level as far as the company's perspective is concerned on the low arteries, but definitely we have been using it in acute decompensated heart failure, and that has been shown to decrease the outcomes in these group of patients.
So then Viveka, for our
difference in right-sided and left-sided acute decompensated heart failure?
No, so I think it is mainly studied for left-sided acute decompensated. Right-sided is something which is not important.
So, Dr. Viveka, after those 4 foundational drugs, is there a 5th, 6th and a 7th drug to be given in heart failure? I am referring to the SGC, I am referring also to ivabradine, I am also referring to the GLP-1 agonists.
Yes, so if you look at the current evidence, that clearly shows that the most upcoming molecule is Valisiguard, which is approved in worsening heart failure, but we have got now the trial is going to be over, which is there because that is something like cyclic ATPs, cyclic and ATP where the cardiac energy level will go up. So in that situation, the Valisiguard would be probably the 5th pillar, and as you rightly said, the GLP-1 receptor analog, we have got enough data now from the tirzepatide and these molecules that this is going to be, so that has shown to be more effective in patients who have got heart failure with preserved ejection fraction. But definitely this is something which is to be studied in HFrEF as well.
Sir, my last question.
That is huge amount of weight loss that it induces, which puts less stress on the heart. Molecules like Mounjaro.
Symptomatic.
So I think yes, but definitely the other markers also, the cardiac performance markers and all, they are also better. Yeah.
So my final question, Dr. Viveka, would be regarding ARNIs being effective in very advanced heart failure, because there is a blunting of the natriuretic peptide here, and also patients who had a prior MI, a recent MI, we don't need natriuretic peptide here. If they are not in heart failure, we don't need natriuretic peptide here, sir. So probably can you dwell on ARNIs in acute myocardial infarctions and in probably effective in very advanced heart failure because of blunting of the natriuretic peptide here. As compared to the ACE or the ARNs, which are equally efficient. No advantage seen with the ARNIs here as compared to the ARNIs, as compared to the ACE and ARBs. Thank you, sir.
Yeah, so I think that's a very good question, and if you see, it does not, so the people had a perception probably the ARNI would do harm in these situations. That's not true. It did not reach the superiority, so there was no superiority. So if you continue with ARNI, that's good enough. But if you expect that in acute myocardial infarction or ATM, if the patient, if you feel that if you give ARNI, you are doing some good to the patient, that's not true. So I think in these situations of acute myocardial infarction and all, giving ARNI would be as good as giving the S inhibitor. So give molecule, if the patient has got hypotension, we give the perindopril and all, which does not induce significant hypotension. But if the patient's blood pressure allows you, might as well give ARNI and give them the best blood, because acute heart failure would eventually go to the chronic heart failure and you will continue the same medication.
My very last question would be regarding GLP-1 agonists in heart failure with reduced ejection fraction, conflicting data. See, some data is suggesting, Lancet for example is suggesting probably worsen heart failure by triggering ventricular arrhythmias, by triggering atrial arrhythmias, by triggering ischemic heart disease as well. So patients who have reduced ejection fraction, you have to be a little cautious in prescribing GLP-1 agonists.
Very good. Except for the patients who are
obese.
Obese, yeah.
Wonderful, sir.
Thin obese is something which is wonderful.
Thank you, sir.
I would, Dr. Amish, you are not going without having your dinner. I'm sorry.
We'll give you the chemotherapy.
You have to have our diet therapy, please. I would request Dr. Sen Gupta to please summarize this wonderful CME for us. The dinner is here only, downstairs.
So I think we all go back tonight hugely invigorated with the knowledge that where to place ARNIs as well as the pros and cons, which has been beautifully discussed in the fantastic panel discussion and also from the questions from the audience. And I think we can all call it a day this evening because we have had a wonderful discussion, and I hand it over. And I would ask for a vote of thanks by Ujjwal from IPCA, deliver his vote of thanks. We have had a wonderful evening session. Thank you very much for this.